Hello, and thank you for joining me today. My name is Ryan Halabi, and I will be presenting my policy brief on childhood and adolescent obesity. But first, a little more about me. I have a background in both medicine and business, having obtained my MD and MBA from St. George's University. I'm currently an MPH student, and I'm also working within the healthcare sector. With that said, I have had firsthand clinical experience of the health implications associated with pediatric obesity. The key message of this brief is to increase awareness to, investment in, and action for the adoption of cost-effective policies and interventions that can help guide key stakeholders at the local and national levels towards effective primary prevention strategies that combat pediatric obesity in order to optimize the population health outcomes of our youth. This brief is intended specifically for four key stakeholders: local and national governments, policymakers, public institutes, and community leaders. The CDC defines obesity in childhood and adolescence as those individuals of the same age and sex with a BMI at or above the 95th percentile. Simplified obesity is the imbalance between caloric intake and caloric expenditures. The prevalence of obesity within our youth has increased globally across both developed and developing nations, with 17% of US youth now considered obese. Additionally, pediatric obesity is a public health threat that is not limited to those marginalized within society, as it impacts youth across a wide array of cultural and socioeconomic backgrounds. The rise of obesity into one of the greatest public health challenges of the 21st century has been driven by lifestyle factors that are often a product of systematic factors leading to poor diet and lack of physical activity. Obesity in youth has serious adverse health effects that continue into adulthood, culminating in premature morbidity and mortality. The negative health implications include neurological, pulmonary, and gastroenterological disorders. Additionally, cardiovascular and endocrine systems are also implicated, with these individuals experiencing a higher prevalence in coronary artery disease, risk factors such as high blood pressure, high cholesterol, and diabetes. Pediatric obesity is also not only confined to physical health, as it also carries with it negative mental, social, and economic implications, specifically amongst the adolescent age bracket. These include poor self-esteem, body image, and lack of economic mobility. Pediatric obesity also reflects negatively on social and academic progress, leading to social discrimination and stigmatization by peers. Moving beyond health, pediatric obesity also has economic and ethical repercussions. The annual direct cost of pediatric obesity in the US is $14.3 billion, while the annual indirect cost is $4.8 billion. The cost incurred when obese youth become obese adults in the US is $147 billion. Thus, pediatric obesity doesn't just impact health, it also impacts the nation's economy. The ethical dilemma at the heart of childhood and adolescent obesity policy interventions is a clash between autonomy and state authority. In other words, should policy interventions limit state authority to ensure individual freedom or place individual autonomy secondary to the overall welfare of the community? Our approach to address this ethical dilemma is to utilize the harm principle. The harm principle proposes that state intervention is justified if an individual's actions affects others. It shifts the responsibility to the state in protecting vulnerable populations from self-harm and harming the health of those around them. Thus, this harm principle can be utilized as a basis towards a utilitarian view where optimal benefits for the greatest number of people can be applied to policy interventions for the benefits of vulnerable populations. Analyzing the current literature, the response to combat pediatric obesity has resulted in the implementation of numerous regulations across a wide array of sectors. Utilizing a cost-effectiveness analysis is the ideal approach to determining the ideal intervention to combat pediatric obesity. Cost-effectiveness analysis is an economic tool that is utilized by decision makers to compare potential interventions based on cost per quality adjusted life year. Ratios less than 30,000 per QALY are usually considered a strong return on investment. And we did that to assess the current literature and the interventions out there. Based on this analysis, the intervention that is deemed to be the most cost-effective in prevention of obesity amongst youth is the Coordinated Approach to Childhood Health, or CATCH. CATCH is a comprehensive intervention that promotes physical activity and healthy eating within elementary schools costing $900 per QALY. Planet Health was the second most cost-effective intervention, which did the same thing but at the middle school level. Interestingly, tertiary prevention such as prescription drug management or surgical intervention to treat adult obesity are significantly less cost-effective. Thus, when comparing prevention strategies with treatment-based interventions, the best course of action from both a fiscal and health point of view is upstream primary prevention that utilizes health promotion and education rather than downstream tertiary prevention that utilizes acute and chronic medical and surgical management. While conducting our analysis, there were three major critiques that we noted. One critique of current interventions is that while school-based interventions are effective in the short term, they tend to lose this effectiveness over time, as most are of short duration. Another critique is that these programs often do not follow up the individuals into adulthood to gain further insight into whether the weight loss achieved as a result of these programs is sustained and whether or not health outcomes are improved as a result. Finally, a lot of these programs are too simplistic, focusing solely on a specific curriculum or one aspect of childhood obesity. And there needs to be more integration and a multifaceted approach to these interventions instead. With that in mind, and after analysis of the current literature, we propose a list of 11 policy framework actions that we urge you, the stakeholders, to adopt. These include health promotion and education that take into account cultural beliefs and attitudes across public institutes, the provision of healthy nutritional food standards across public institutes, stringent food labeling mandates, stricter regulation and limitation on sugar and sweetener content in commercial products, subsidization of healthy nutritious food items such as fruits and vegetables to promote healthy dietary choices and reduce financial barriers to ensure food security, subsidization of recreational activities such as gym memberships and sporting activities that promote physical activity and reduce financial barriers to these activities, public infrastructure investment that promotes a healthier and more active lifestyle such as investments in sidewalks, bike lanes, and public green spaces, restricting the marketing of unhealthy food products aimed at children and adolescents by introducing restrictions on advertisements at public institutes, investing in community planning that promotes healthy nutrition within neighborhood setups, investing in research to gain more insight into the root etiologies of childhood and adolescent obesities, and finally, investments in continuous monitoring and assessments of the progress of these policies and interventions in order to continue to shape policy towards maximum benefits of reducing childhood and adolescent obesity, as well as increasing the cost effectiveness of these interventions to the best extent possible. The proposed multifaceted approach presented here aims to ensure sustainable physical, mental, and social well-being at both the individual and community levels in the most logistical and cost-effective manner that ensures constant monitoring and assessment of interventions to continuously shape policy in an effort to attain maximal returns on investment. The limitations of these proposed policy recommendations include potential government fiscal limitations, cultural resistance to change within communities, and difficulties inherent in progress assessment and monitoring, as many of these interventions require lifelong monitoring of the target audience, creating additional temporal and fiscal challenges. In conclusion, childhood and adolescent obesity is increasingly becoming one of the largest public health issues of the 21st century. Failing to intervene will have severe repercussions in physical and mental health, social well-being, and economic prosperity across both individual and community levels. The most successful and cost-effective strategies to combat pediatric obesity involve upstream primary prevention interventions that utilize lifestyle modification behaviors, particularly diet and physical activity. The proposed multifaceted policy framework of action in this policy brief integrates health promotion and education about healthy nutrition and the importance of physical activity in childhood and adolescence, with governmental policies aimed at placing public interests ahead of commercial interests, while also creating an enabling environment that promotes positive lifestyle choices. I would like to conclude by thanking you once again for taking the time to listen to this policy brief. I hope to see some of these interventions implemented in the near future. Thank you.